Hey everybody, let me know if you can hear me. How are you? It's good to see everybody tonight. I got a few housekeeping things that I wanted to do before we get started, so I'm just going to read them off because I printed them off. So I want to, of course, thank Legendary Milk for asking me to hop on today and discuss risk factors for low milk supply. However, I'm not affiliated with the company, so if you have any product related questions, please reach out to them directly. And then all opinions are my own, and any info presented should not be construed as personal medical advice or diagnosis. So thank you all for tuning in. I see little hearts. That's exciting. So yeah, I worked all day today, and then I came to talk to all of you. I need to see if I can get closer to this so I can see you guys a little bit better. Let me see. Let me think how to do that. What if we move this right here? Can we do that? In the middle of like all of this, I know. And then we'll get started. Hi everybody. Hi. Happy Black Breastfeeding Week. I don't know if everybody knows that that's what this is, but it's National Breastfeeding Awareness Month, and this is Black Breastfeeding Week. It started yesterday. We're moving the tripod, so yay! I think you'll be able to see my balloons from the lift left over. Oh yeah, that's better. Perfect. Thanks. All right, guys. So today's topic, or really what I wanted to talk about today, we're going to talk about tongue tie. I'm Montika Collins, where you can't hear. Can anybody else not hear me? Hey, Jules, can you turn that sound down? If you can hear me, raise your hand or say something. You guys can hear. Okay. I don't know why you can't hear. So I'm glad that good. I'm glad you guys can hear me. Okay. All right. Yeah, it's good. They said some other folks said they could hear, so I don't know what was going on with her phone. Okay. So anyway, it looks like we got quite a few people. So thanks everybody for checking in. Again, happy National Breastfeeding Awareness Month and happy Black Breastfeeding Week. My name is Montika Collins. I'm in Oklahoma, Tulsa, Broken Arrow area, and I am a nurse. I am a lactation consultant. I don't do a lot of live stuff, so forgive me if I'm stumbling over my words a little bit here. But yeah. So Oklahoma, I was a NICU nurse for a long time. Also did some postpartum and mother-baby work as well. So I'm an RN, a BSN. I'm also an IBCLC, and that is a international board certified lactation consultant. I also went through the CLC program, and that is a certified lactation counselor. I also am a health and wellness coach and an herbalist. So a lot of what I do is more advanced lactation support. So I kind of wanted to come on and talk to you guys about that. So I read over some of the questions. I know a lot of you saw the picture that I put on there with the different shots of babies' mouths. And can I move to Cincinnati? I don't want to move. That's far though. So I saw where some of you guys were looking at the pictures and actually, saying my baby has this and my baby has that. I feel like we get into that a lot. People look at a lip and you see a frenum and you're like, oh, my baby must have a tie. We all have frenum. What is the issue is if it is restrictive or not. And the way to find that out is to get an assessment. And a good feeding assessment or assessment at the breast, which is what you need for breastfeeding, is going to come from an IBCLC. We are trained to actually do feeding assessments at the breast. So IBCLC would watch you feed, and IBCLC would be able to tell you, how much your baby is transferring, if your baby is transferring or not. And if they're not, we can troubleshoot as to what it is, why your baby, isn't transferring, and things like that. So I want to say, kind of backing up, where I'm at is called Total Family Wellness. So if I don't answer your questions completely, or if you guys have any extra questions after this is over, you can check out my page. I have a Facebook page, and my Facebook page is Innovations Lactation and Breastfeeding, I think. And then my Instagram page is total_family_wellness. And the link to my Facebook and to our website is on my Instagram. So I can, follow up with you guys. And if you're out of state and you need some help, I should be able to do that as well. Also on my website, there is a link under resources that has a list of IBCLCs that have taken a master class, and they are very Thai savvy, because everybody's training is a little bit different. Everybody's training and background is going to be different. Just like with any doctor, with any dentist, speech pathologist, I don't care who it is, nurse, we've all done different things, and we've all chosen to specialize in different areas. So I would like to, really just kind of talk about what I see the most, in dealing with babies that have oral restrictions, and oral restrictions are tongue ties. So you have 7 oral frena. They can be tight. Here you have your upper buccals, you have your lower buccals, you have this one here, your lower lip, you have your upper lip, and then you have under your tongue. So I actually have a pretty good lip tie, which is how I have this diastema, which is a gap between my front teeth. And when you have oral restrictions, it not only can affect breastfeeding when you're a baby. A lot of babies that have oral restrictions also can be really colicky because you don't make a proper food bolus when they're eating. Also, even as they get older, if you're not, digestion, it starts in the mouth. So if you're not able to get your food down and swallow your food properly, they get a lot of excess air and stuff in their bellies, and your tummy's not supposed to have air in it. So, they'll be super gassy, super uncomfortable, and those types of things. Not the biggest fan of reflux meds, and there's lots of new research coming out now about the different reflux meds affecting, babies' bones and things like that. So we really want to, what I do at my practice is I try to find what's going on with the baby, find out why the mom is having the pain, why the baby is colicky, and then we want to actually fix that. We want to get down to, to the root of the problem, not just throw some medication at it and say, okay, now the baby feels better, while those things are still going on and we haven't actually, fixed it. So I would say other things that, I see a lot of is babies that, people are saying, well, how do I know, if my baby has, a tongue tie? Number one, it shouldn't be painful to breastfeed. I don't understand why people were still having this discussion, but that is like a discussion. It shouldn't hurt to breastfeed. If breastfeeding was painful, we wouldn't still be around as a species, because people are not going to keep doing something that is painful. So yes, lots of things have changed. There's all kinds of different theories as to why, we are having the troubles that we're having breastfeeding, but we do have trouble. And I think a lot of issues that I have with telling people, oh, well, breastfeeding works. Well, breastfeeding should work biologically. In a perfect world, breastfeeding works. But then when you add in the stress of the world that we live in, when you add in the fact that, we don't really have a village, even though we say, oh, it takes a village. Most of us don't have a village. Most of us, get married, we move away from our family, we go to college, and so it's just us, So a lot of the clients and mamas that I see are home, and home alone, and their partners have to go back to work because we don't really even support that. We don't have things in place. And I know that those things are changing as well, but big ships, turn really slow. So, we need to have more support for our parents, for the fathers, and the mothers, the partners, whatever your family relationship looks like. That could even be a daughter and a mama, that would be the grandma. But whoever is helping out, when you're looking at like FMLA and those different types of things, moms need support. We have mamas that are going back to work, at 2 and 3 weeks, and we're saying, breastfeed. And that's very hard to do. When you, breastfeeding is hard on its own. And then, being a new mom is also challenging. But then when you add oral restrictions into that, it can be super stressful. And if you had a colicky baby in there, it is unreal. My oldest daughter, she's 13 years old, and she was horribly colicky. And it is bad. Like, when I think about it, it literally still brings tears to my eyes because she would just scream and cry and scream and cry. And my mom would say, well, this isn't normal. Took her to the pediatrician, and they, basically, you just have a colicky baby. It's okay. Lay him down, and leave the room. It's okay to walk away, which it is, but that's my baby. I don't want to walk away from my baby. I want to help, my baby. And I remember, being in the room with her in the middle of the night, and at that time, Damian Marley's CD, I can't remember which one it was, but there was a song on there called There For You. And I would turn that song up as loud as it could go, and I would sit there and I would rock with her, and we would dance, and she would cry and I would cry, and it was mind-numbingly horrible. And I had absolutely no support. And, come to find out after learning, and people say you're passionate about what you do because of a lot of times your experiences, and for me, having a colicky baby who also ended up having a dairy allergy because she had crazy eczema, and she would scratch the back of her neck until it would bleed. It was just rough. My daughter had a rough start to it, and all I got from I didn't know about lactation support then. And like I said, this was 13 years ago. So, it was, here, put this cream on it. You can put some Lubriderm or some, steroid cream on it. And again, she's colicky. So basically, we're sorry. That was pretty much it. She was gaining weight. I was fortunate because I had quite a bit of milk. I had actually kicked in the oversupply, which is a thing, and so I'm very hesitant a lot of times. Kind of side note, I know a lot of my colleagues will, oh, you have oversupply, let's do something to bring the oversupply down. But a lot of times your body is compensating for the fact that your baby can't properly extract the milk out by actually having oversupply and an overactive letdown so that you can passively feed your baby. So you put that baby to breast, and that baby who can't suck right because they have the oral restrictions, which my 13-year-old is horribly tied. Like I said, she's got the snake tongue and everything, but no one saw that child's tongue. But I was able to put her to breast. I had, plenty of milk. She was fat and gaining, and so the pediatrician was like, she's fine, she's healthy, and being miserable and in pain and your neck bleeding is not healthy to me. So even our gauge for health in this country is so kind of skewed, because most of us are unhealthy, in some way, shape, or form, from our diets to the processed foods that we're eating to, folic acid. That's, everything is fortified in folic acid. And so many people have MTHFR, which I'm not getting ready to go and open that can of worms right now. But, regardless, it's difficult for us to break down the folic acid. So if you can get a prenatal that has folate in it, is going to be much better for you, because tongue ties are a midline issue. So, things like spina bifida, sacrodentrals, heart stuff, tongue ties, you'll see stork bites. Those types of things are, midline stuff that forms within the first 4 weeks, of your baby's life. And the issue with that is most of us don't know that we're pregnant until after that first 4 weeks. So in my opinion, every mama or young lady that is in the position to where she may get pregnant needs to be on a good vitamin. It doesn't have to be prenatal, but you need to be on something to where you are actually getting folate into your diet. And then, of course, having a diet that is rich in folate, and so I won't go down that road either, but, getting, plenty of greens, making sure that we're eating right, and those types of things are going to be really important. So part of also what I do, with being a health and wellness coach and an herbalist, and also trying to help, again, I said this was Black Breastfeeding Week. And so Black women and babies are very close to my heart because I am one. And I have 3 of these little Black people running around here. I have 2 girls and a little boy. And they are 13, 7. My son just turned 7. And then I have a 5-year-old little girl named Cadence. So we want to, let me back that up too a little bit when we're talking about breastfeeding and, just overall health stuff. Here in Tulsa, Oklahoma, the Tulsa Equity Committee, they kind of look at all of our numbers and all of those different types of things. And the numbers for our Black infant mortality rates is 4 times the rate of our white babies. And that is a problem, and it is devastating, and it is so not okay. And it's very frustrating to me that people aren't outraged by those numbers. Now, our mortality rates, our maternal mortality rates in this country are, not good by any means compared to other, established countries, of course. But when you look at the rate that Black women are dying during that, perinatal period of time, our maternal mortality rates, when you look at our infant mortality rates, there is a problem. And for me, my niche, or what I'm good at, is breastfeeding and helping mamas, to breastfeed and to get good at that and to understand, the dynamics around that and to actually treat the diet. And breastfeeding is shown and proven, the research is there that says that helps bring down maternal mortality rates. Breastfeeding brings down infant mortality rates. And it's not just the breast milk. It's interesting to me that everybody's kind of got on this breast milk thing that, oh yeah, you need to get breast milk, but the act of breastfeeding is so important. And I believe that every mama should have that chance to be able, to breastfeed if that's something that she's interested, in doing. So when we're talking about, those types of things are some of the other things that I do as a lactation consultant, and where, it's important. Breastfeeding, again, it shouldn't be painful. So if you're having pain while you're breastfeeding, you want to reach out to somebody. But I also suggest that you research the background of the people that you are asking to help you, because like I said before, everybody has different trainings and expertise. So just because you get an IBCLC, if that IBCLC is not tongue-tie savvy, if that IBCLC does not understand how oral restrictions also affect gut health, that's not the one that you want. Now, if you're just having some basic latch issues, or if you see someone, anything else, those things can be handled by someone else. But if you know your baby has oral restrictions, you want to get with an IBCLC that knows how to work with the dyad, as far as helping mamas that have babies that have tongue ties. I believe that, whenever I get a baby that has an oral restriction, and people are just, very quick to, oh, well, you need to see the dentist so that you can get it fixed. It doesn't work well that way. I also see a lot of older babies, and my families, or I shouldn't say my families, because my families, I push very hard to have a multidisciplinary approach when you are, dealing with oral restrictions. And a multidisciplinary approach includes, me being an IBCLC, someone that does body work as well, and that would be myofascial release. I think craniosacral therapy is good, but I believe that myofascial work is more beneficial with these babies than just the CST. But I think the CST with the myofascial work is, a great combination. So when I work with babies, because I do body work as well, I do CST and I do myofascial work with my clients. But you may not have an IBCLC that has taken the extra training to be able to do that. So then you would be looking for someone else to be able to do that portion of it. And then, of course, you're a dentist. But the thing is, with these babies, if you have a baby that has oral restrictions, that chance of that mom actually having nipple damage is so high. And the dentist is not going to look at your nipples. The dentist is not going to be able to help you if you get mastitis or thrush, or, catch it early or anything, like that. So those are the types of things that, you could go to some of these other providers, but you need someone to make sure that your baby is transferring enough milk. If the doctor is saying that, hey, your baby is failure to thrive or whatever, or is borderline, someone that can help you to get donor milk, someone that can help you, if you want to make your own formula, or that can talk to you about what else is out there, your options. If you want to, if you need to use a nursing supplementer to get, milk inside of your baby, help you learn how to navigate all of those things so that you can get your baby fed while you are preparing your baby to get revised. Because we do want these babies to eat, but, it is definitely important as well to be able to breastfeed. And if you've got open sores, then your chances of getting mastitis have just, skyrocketed. So we want to make sure that we get you healed up while we're going through the process of getting your baby ready to get revised. And so you're going to spend, a few weeks, and really I believe in oral habilitation with these babies, doing exercises with these babies, and it's not, if you have an older baby, someone that can follow directions, or if you are an adult, then you would get an OMT, and that is someone that can actually teach you how to do these various exercises, how to swallow properly, putting your tongue in the right place, and those types of things. But those aren't things that we can tell a baby to do. So basically, what I do with my clients is I teach them how to do different exercises with them that they can be doing while we are preparing for those babies, to be revised if that's what we're going to do. Other things that I feel like are really important when we're talking about doing myofascial work, I liken it to doing exercises or being in shape. When you are, your tongue is a great big muscle, right? So when you're talking about when you're in shape, you can get into complete splits. You can get those legs open. Well, those are the same legs that, once you, stop working out, you can't get those legs open. You know what I mean? At all. That muscle does not move. So, but let's say you decide to get back in shape again. Now you can get into those full splits. So a lot of what we're doing is getting in there, working the floor of the mouth, working with the jaws, working with the hips. The tongue is connected all the way down to the toes. So you really want to have someone that can work with your baby's complete, with the whole body, basically, is what I'm trying to say. You want that baby to unwind. You want that baby to be able to have as much range of motion as possible before you go in to have the revision. So basically, when you go in, instead of the doctor being able to rate, pretending this is the floor of the mouth and this is the tongue, instead of the doctor being able to get here, you want that baby to be able to get here. So the doctor can get far enough back, and get that posterior portion of the tongue so that you can have a complete release and you can have complete range of motion, with that baby. The other things too that are super important with working in the baby's mouth before is that baby gets used to having fingers in its mouth, and that mom gets used to working in that baby's mouth. I've seen mamas that are scared, to actually get in because you have to do elevations or stretches depending upon who you ask, post-operatively, because the tongue likes to rest on the floor of the mouth, right? And so it'll heal back down here if you don't actually lift it off the floor of the mouth. And so most places, are 4 or 5 times a day or 5 to 6 times a day, of actually elevating the tongue off the floor of the mouth. It's a quick thing. You just go in and lift it up, but who wants to, hurt their baby? And if you're not used to getting in there, you can be a little trigger shy with what you're doing. My chickens are squawking in the background, so I don't know if you can hear that, but that's what that noise is. So anyways, we want to get you ready and get the baby ready, for that post-op, time period. So I have my moms and dads working in those babies' mouths, getting them used to it, them going in, doing exercises, working, so they know, and the babies know that every time someone's finger goes into my mouth, it's not painful. You know what I mean? They're like, oh, okay, I'm used to this. And then once they have this owie procedure done, at that point, then I make sure that when mamas go to do their stretches afterwards, I have them wear gloves, because I don't want my baby's associating anything owie with my mama's flesh. There's flesh on your nipples, there's flesh on your fingers. You're still going to be doing exercises with that baby. And a lot of the exercises that you were doing before, where your baby didn't have the ability to be able to do it, now they do. So, think of it like a surgeon. Let's say you were never able to walk, and then the surgeon goes in and they fix your legs, so now you can walk. It's not like you jump up and you just start walking, right? You have to learn how to walk. And that's why you go, to therapy and you learn how to walk. And first you crawl and you get the bar and you do all of those things. So we are going through the motion of exercises in the beginning, right? And then after that, now that baby has that new function, that new range of motion that they got from getting released. And now we can actually go in and help that baby to be able to suck properly, because again, that baby has been sucking. Babies suck for comfort, and babies suck in the womb. So that baby's been sucking the way that they've been sucking the entire 9 months and plus however many months that it's been, until you get to that point where you actually are saying, hey, now we're going to get this baby revised. So it's not going to be an overnight thing. I feel like a lot of mamas, of course there'll be that occasional mama that's like, I got my baby revised and, the heavens opened up and I don't have any other problems. But I also see with that, I see babies get just the anterior portion of their tongues clipped, and those mamas tend to have a lot of pain. And I've seen, owie hamburger nipples, you know what I'm saying, with babies. And those mamas, they don't have any pain anymore, so they think that everything is okay. But if your baby doesn't have a complete release, there's other things that can happen if that release isn't complete. And you'll see, mouth breathing, in these babies. You'll see babies that are snoring. You'll see apnea, in older kids. You're not supposed to snore. You're not supposed to, breathe through your mouth. We're supposed to breathe through our noses. And so, those types of things, bedwetting, the dark circles under their eyes, they get a ton of stomach upset from swallowing the air all the time. So you'll have the colic like I spoke of earlier. Also, they have more allergies because basically your body cannot be, it's not going to be allergic to air. So there's something that's making it mad. And so it says, I don't know what it is that's making me angry, but I'm going to react to that. And so whatever that mom is eating a lot of, that baby's body starts building up sensitivities to that. And so with that, then you have people that tell mamas, oh, the baby is allergic to your breast milk. That's relative. It may be allergic to something in your breast milk, but that doesn't mean we need to take your baby off your breast milk. That means that we need to help the baby, heal the baby's gut. We need to revise the baby so the baby's not taking in as much air. And when you get extra air in the stomach, that's called aerophagia. It's actually really a thing. And it can look like reflux and these different things. And that's, not necessarily what it is. So we want to fix those things, and then we can take things out of the mom's diet so that the baby can handle that breast milk and still be comfortable. And then we heal the mama's gut, we heal the baby's gut, which we're not going to get into gut healing today as well. But I'm very, very big on gut healing because it's very, very important. But you want to be mindful of the things that you read, the advice that you get, because a lot of people just really don't put those things, together. Those, babies that have, all of these allergies and things like that. Those types of things, the mouth breathing, the bedwetting, picky eaters, babies that are picky eaters, the texture babies, the ones that are like, don't want to eat anything. A lot of times it's hard for them to chew. It can also affect your speech later on in life. And those are the things I feel like everybody's really aware of. It doesn't matter until it starts affecting the way that they talk. By the time you get to that point, they've already been walking around with all of these difficulties before you actually can see them not being able to speak or having delayed speech or anything like that. So, when you're a mouth breather, it literally it's a problem. You're supposed to breathe through your nose. You're supposed to filter the air when you breathe through your nose. You humidify the air when you breathe through your nose. And then it goes down into your lungs. When you breathe through your mouth, it's just air on your tonsils and on your adenoids. And so you see a lot of children that have, just these huge tonsils, have to have their adenoids out and different things like that. So those are going to be, some other symptoms of oral restrictions that you're gonna see. In adults, you've been not oxygenating properly while you're sleeping, because when you snore and you have these apneic episodes, because basically your tongue is the template for your palate. So your tongue should rest in your palate all the time. When the tongue can't rest in the palate sits up. So you'll have these babies that have really high palates, and I think that was one of the slides that was in there. And I've seen palates that are so high that you could they can pocket food in there and all kinds of things like that. But not only does it not sit here when they're sleeping, it falls into the back of the throat. So when it falls into the back of the throat, then it's obstructing the airway. And that rattling, snoring sound that you have or that you may hear while they're sleeping is from that. You'll also see, teeth grinding and all kinds of stuff. My babies, like I said, my oldest has a really bad tongue tie, and we're actually going to get her revised soon. For us, it's just been more of a timing and a money issue. And I know we all have those. And then my son, he choked when he was 4. Because people that have oral restrictions, they can choke a lot easier as well. So just my side note advice, when you are giving your babies grapes, cut them in half. I'm not one to live in fear, but I am one to use wisdom, and we definitely still eat grapes at our house, but we cut our grapes. And it's not that he can't chew, but, toddlers don't, preschoolers, they don't sit still. They're up and they're running around and so on and so forth. And so I had someone tell me, well, it wasn't someone, I think it was I don't know what kind of doctor he was. I think he was a pulmonologist, was telling me that they're walking along and then they have food in their mouth and they trip. And when they trip, they go, and as soon as they do that, whatever that grape, hot dog, whatever, goes into the back of their throat and it gets stuck. So I was a nurse. I did all the things. I know how to do the Heimlich. And I could not get that grape to move. Me, the ENTs, no one could get it to move. We didn't even get it moved in the hospital, and it was super scary. And I won't go into that as well, but my son is alive and well. Thank you, Jesus. That was, just a blessing that he is even still with us. I would say my youngest, her mouth looks the best, but I also have changed my diet and learned since my older one. So I take methylfolate actually now, and have been, for a while. And so Cadence, the baby, I would say her mouth looks the best out of everybody. But it's definitely, a learning curve. And I feel like we're all, learning, and we're all trying to do the best that we can, with these little people, but they shouldn't. They shouldn't be loud. They shouldn't be loud sleepers. We shouldn't be loud sleepers. I watch TV commercials, and, it's like the way sleep looks as people are, open mouth breathing, drooling on the bed, that is sleep disorder breathing. That's not how you should look when you're sleeping. So, trying to back to some of the questions that I saw from y'all about the different pictures that were posted. Biggest deal I'm gonna say, and I can't say it enough, is to get your baby to someone that can do a good functional assessment, because you're gonna have frena, and you don't want to go to somewhere that's just going to revise just because you walk in the door. If that frena is not restrictive, then it doesn't need to be cut. And so you want to make sure that, you get that assessment from someone that knows what they're doing, that can assess that baby at the breast. And a good IBCLC can also, assess at the bottle. If your baby is taking a bottle and all of the milk is like coming out of the side, that's not a good seal. And if that baby can't make a good seal at the breast, it's not going to make a good seal at the bottle. But a lot of times we don't care about all of this milk coming out of the side, because most of the time it's formula when you're seeing babies do that. And I've seen, like I said, in the NICU, I'm feeding babies, there's more formula in the burp rag than it is probably, even in the baby. So, we just feed them and feed them and feed them, and those types of things. So you want them to be able to make a good seal. You want them to be able to extract milk from the breast properly. Another thing that I wanted to mention during this one, I see a lot of older babies. So, that first few days when it's just colostrum, if that baby is not causing you any pain, you may not notice it. If that baby is gaining weight and you guys are doing good and powering through, especially my first-time mamas, if your body has kicked into oversupply and you're doing really great, and I shouldn't say only my first-time mamas, I've seen it in families with multiples as well. You'll think everything is going good, but when you get between that 2 and 4 month mark, a lot of times you'll see where those babies start to plateau in their weight. Or you'll see where that mom is like, I had all of this milk and now I don't have any milk. I don't know what's going on. I don't understand. I need to be able to feed my baby. And they go back to the doctor, and the doctor tells them, oh, well, it must be something hormonal with you. You need to, start them on formula. And a lot of times it is the oral restrictions, again, that is creating the problem, because that baby was never effectively driving your supply. Your body was making milk because that's what we do after we have a baby. Your pregnancy hormones, everything is endocrine driven. That's what we do. We make milk. Now, once it switches to where it has to be supply and demand only, if that baby can't empty that breast out, then you're going to see that supply tank. So I see a lot of moms, during that time, and, we get them pumping, we get them, on herbs and things like that. and we figure out what's going on with that baby, and if that baby has to, get its oral restrictions or tongue ties, revised, then we do that at that time. And it takes, it can take 4 to 6 weeks, before you really even see any changes post-operatively. But once that baby can suck, then those moms and babies have gone on, my babies will go on to nurse, for 2-3 years, or for as long as, that mom wants to breastfeed. So I know in our country, breastfeeding is for at least a year, but everywhere else, well, the World Health Organization recommends at least 2 years. And I just say, nurse your baby for as long as you guys are comfortable. I nursed my youngest until she was 4, a little over 4 years old. I nursed my son until he was 3, but I was tandem nursing them, and that got a little stressful. So I'm not here to talk about tandem nursing either, but it was like he claimed this breast and she claimed this breast, and then I had like this argument going on at my chest all the time, and I was like, okay, this is a lot. And so I told my son, I said, well, when you turn 3, we're gonna have, a little party. You're a big boy, you don't have to nurse anymore. And so we kind of did, and so he was done nursing. But I'll tell you what, that little boy, when Cadence turned 3, he remembered what I said, and he was like, Mom, she's 3, so are we having the party? Because it's time for her to get off the boot. And I was like, So yeah, I had to explain to him that it was a lot on Mama nursing them, both of them, and that I was gonna keep nursing Cadence, but at the time it was hard for me to nurse him and her. And hey, buddy, now we can do other things. You can do stuff that Cadence can't do, and you get all the hugs, and we get to hang out and go to the movies, and Cadence is still small, so everybody's parenting journey is different, and we all do what we have to do. But I will tell you, they love to nurse, and they love their mamas, and with Cadence, when she was old enough, then when she was done, we were done. I have another interesting story, since I'm storytelling right now. The Cadence, we were done. My father got super sick, and I was gone, and we were, like I said, she was 4. And so another thing, people think that, oh, once you're 4, once they can ask for it, they don't need it. It's not like I'm walking down the street in Target, nurse. And if I was, then that's my business. But we usually only nurse at bedtime and at nap time, and it was like my superpower. If I put Cadence or any of my kids on the breast, they would go to bed. So I didn't have to fight about nap time. I put them on the breast, they go to sleep, then I have some peace. But I had left, and I really was questioning if I had milk left. And I would ask Kate sometimes, there's no milk in there, girl, Then she's like, yes, there is, yes, there is, yes, there is. So I left and was gone for 2 weeks, and came back. I didn't take my pump. Like I said, my father was really sick, and I just could not wrap my mind around trying to pump. So I didn't. I just said, I guess this is going to be it. Came back, and Cadence asked the nurse, and I said, no, baby, I don't think there's any more milk in there. And, I think we're done, and she wasn't heartbroken, but, we just stopped. So then about a month after that, I was working in the hospital still, and I did overnights, 12, 13-hour shifts as a nurse in the hospital. And Cadence had gotten sick, and she was throwing up, and she couldn't keep anything down. And at work that night, I went on ahead and went to work. My husband was with her, and I just remember my breast getting super full. And it was crazy because I hadn't been full in I don't know how long. And I was like, okay, well, I guess I need to nurse my baby. So when I got home, I put Cadence to breast. And my breast milk was the only thing that she could keep down. She did not throw up the breast milk. We basically stayed in bed all day, and we nursed all night. I didn't go to work that night. I stayed home with her, and she did not throw up again. She ran some fever, and I let her do that, and we nursed, and I had plenty of milk for her. And then the next day, she was feeling so much better. She was doing great, and I mean, that was really amazing to me because I didn't think I'd never heard of milk just coming back. You know what I mean? Like that. I was like, wow, our bodies are really, really awesome. And then after that, when she was better, like my breast started feeling the same way that they had felt before. She asked me to nurse. I told her, hey, you're a big girl. You don't need to nurse anymore. We're still done. And that was the last time that she nursed. But I mean, we literally had went like a month and a half without nursing. And it was absolutely amazing. So our bodies are amazing, and they're really smart. And, you know, if your body is telling you that you need to nurse, my suggestion is to nurse. And if you need help nursing, then get help. I know some really amazing IBCLCs that work remotely. I work remotely as well. It's not my favorite thing to do because I like to put my hands on my babies, and I like relationship with my clients. I'm actually really good friends with most of my clients because we spend so much time together. But yeah, you want to get somebody that is going to be able to help you and support you. I would say some other things that as a lactation consultant that I'm seeing a lot now is just people feeling like they have low supply, but it's really more that the milk isn't coming out. You know, they're able to pump, but when they put the baby to breast, you know, the baby's not able to get it out, and various, I see all kinds of stuff. But when you're talking about breastfeeding and, you know, actual letdown and those types of things, you know, your oxytocin is the milk ejection hormone, right? And the other thing with oxytocin is also the love hormone, right? When you look at your baby and you're like, oh, I love my baby. Like that's oxytocin that's flowing, you know, through your body. It's the same hormone with orgasm with your husband when you're, or any, it's that loving type of, you know, that's what makes the milk literally come out. And if you are super stressed or you're super scared because it hurts every time you put that baby to breast, oxytocin is not flowing. Cortisol is flowing. And if cortisol is skyrocketing up, oxytocin is way down here. So, you know, we could get into like the whole, you know, rest and digest versus, you know, your stress response, your sympathetic and your parasympathetic nervous system and all those types of things. But just to keep from using a bunch of big words, you gotta be able to relax, you know, and get into that zone with your baby, you know, to be able to breastfeed and to actually have, you know, a letdown so that milk is actually coming out to nourish your baby. And I know that we live in a world, in a society where so many of us are so stressed out, you know, so many of us have postpartum anxiety, you know, postpartum depression, all of those different types of things. I feel like I see more anxiety than I see depression, but those things are real. You know what I mean? And those things affect your being able to feed your baby. And then on top of that, when you can't feed your baby, it just reinforces the stress. So now you have even more anxiety because you can't feed your baby. And so those types of things are things that, you know, you want to reach out. You want to get some help. You want to get some support from your local area. I know a lot of doulas, postpartum doulas are amazing. Many of them take, you know, courses in helping with those things, especially, you know, if you want to avoid, you know, the medications and things like that. And they're, you know, for me, I make custom blends for my mamas, you know, to help with anxiety and those different types of things. A lot of times I will just, you know, take the edge off. If you can just take the edge off a lot of these mamas to where they can just chill out a little bit, it is, man, that milk, you know, will flow. Legendary milk products are great. I've kind of looked into a lot of her stuff, and, you know, I don't do live stuff. But I also am not one to, you know, promote galactagogues. But, you know, I also feel like breastfeeding isn't it's not a perfect world. You know what I mean? And if you need to take something to help you, she's got a good quality product. But just make sure that you know, and even with that, a good lactation consultant is going to be able to help you sort through what it is, that you may need. So many people have PCOS. So many people have, I know that they say, well, insufficient glandular tissue is rare, but it's not that rare because I see it. You know what I mean? So it's those types of things, and also even when you look at the different Facebook groups, I mean, we're on Instagram, but I think there's a Facebook group that has like 1 million people on it, I feel like, and it is literally, it talks about, it's for people with low supply and IGT. So, those types of things, it's real, and it's sad that, people jump to the conclusion. Number one, it hurts me that people jump to the conclusion that it's the mom. It's something that you're doing. And I'll tell you, some of my best clients are women that have breastfed before, and they know that their bodies are working, and then all of a sudden they have this baby, and this baby can't nurse. And you take that baby to the doctor, and they're telling you, oh, there's nothing wrong. There's nothing wrong with your baby. Your baby can breastfeed, whatever, or, blah, blah, blah. That baby is gaining weight or whatever. Why don't you just formula feed? Maybe breastfeeding isn't for you. All of the different things that I know many of us have heard. And this one specific mom, which, like I said, she's one of my favorite clients. She was like, I knew that there was something wrong with this baby because this is my 4th baby, and I know that there's nothing wrong with me. But when you're a new mama, you don't have that type of experience and conviction, so it can be difficult. So I would say, through all of this whole conversation that we had, you want to make sure that you are, do some homework about your people. And I feel that way about anybody. I don't care if it's your doctor, I don't care if it's your baby's pediatrician, your IBCLC, your dentist, whoever. Find out, how often do they do revisions? How many revisions have they done? How, what's their philosophy about, doing, revisions? Find out about your chiropractor. Is your chiropractor someone that is, skilled with working with babies? Because a lot of them aren't. Is your chiropractor someone that is used to working with babies that has oral restrictions? Because a lot of them aren't. And if you don't have someone that's good with working with, cranial bones and all those different types of things, then that's not the person that I would want, working on my baby. Now, I still may go to that person for myself, you know what I mean? Because I'm an adult. And if they do a great job with me and my back and how I'm feeling, then that's great. That's not taking anything away from that provider. But you don't want to ask someone just because they're great with you to work on your baby, because your baby is going to be, completely a completely different animal. And then even with your dentist, you want to make sure that you get a preferred provider, and that person, has a track record that you can follow, and meet them, and don't be in a hurry, to get your baby revised. And if you are having a ton of pain, then reach out and get some help, because breastfeeding should not be painful. You should not be bleeding from your breasts and all of those different types of things, but just because it shouldn't be does not mean that it cannot happen. So we need to have, support people to do that. I'm not sure what time it is. What time is it? I don't know what time it is, but I was going to try and answer some questions. Somebody type what time it is for me. You take all the supplements and you don't 8:54. Oh, I've been talking that long. Lord have mercy. So let's see. Let me answer. You take all the supplements, but you don't notice a difference. If you're taking supplements and you're not noticing a difference, then there's probably something else going on. I can throw all the supplements or herbs at somebody all day long, but if you're not getting your breast emptied out on a regular basis, then that milk's not gonna, come back in there. So my suggestion for that is to make sure that, number one, again, get with a good IBCLC in your area, and so that they can look at your breasts, and hopefully you get someone that asks permission to touch your breasts so they can kind of feel what's going on. And if it's, a virtual consult, usually we can look and kind of tell what's going on. But we need to see, what the issue is and find out if it's, the issue is your baby. I don't know if you're pumping or not. And you're taking supplements, but that would kind of be where I would start. What is normal amount to pump? I feel like people don't get all tied up with the whole, you shouldn't have a ton of milk in the freezer. You really shouldn't. Like, people see all of these women that have like freezers full of milk. I believe that has something to do with some inflammatory stuff that I don't have time to go into right now. But, you should pump enough to have enough for a day or two, in the freezer. You don't need like a crazy stash, because technically, in a perfect world, again, we would be, with our babies all the time. Let's see. I think I got time for one more. What extremely painful? Letdowns are owie. For some people, it shouldn't be extremely painful. I would definitely get with your local IBCLC to ask them about that. I hear my children coming in, so hopefully they will keep it down. Nipple tenderness go away. Nipples being tender is one thing. You shouldn't have nipple pain. And it really shouldn't be super tender either. So if that continues for a long time, I would definitely look into trying to get with somebody. There's a ton things like nipple tenderness. There's a ton of like local groups, your CLCs, baby cafes, other local mama groups can be really, really helpful as far as helping you to, get a good latch and positioning. I would say like my favorite thing, one of our local IBCLCs here, Cassidy Holtz, used to say all the time, and I've kind of adopted it, is nose to nipple, tummy to tummy. So you want to make sure your baby is turned in towards you, so their stomach should be up against your stomach, and you want to start, with your nipple at their nose so that they can go. And when they go up like this, there was another question about a high palate. So when they go up, you want to aim your nipple towards the roof of their mouth so you can get, and make a good breast sandwich. So you're kind of like squeezing it all together, and aiming that tissue towards that high palate and making sure that, that baby, because your nipple should be way, way back here, technically. And that's not really, when they're sucking, they should be on the areola, that large, dark portion of your breast. But if you can imagine eating, when a lot of times moms lay their babies down flat, and so then their heads are turned like this. If you were trying to eat or drink like this, it'd be difficult. We face our food when we eat. So you want to face, your baby should be facing your breast, your body when they're eating, so they're not turned, kinked, to the side. So those types of things are things that you should be able to get some help with. I think it's almost time for me to start wrapping up. So I do want to mention again, my Facebook page, Innovations, Lactation, and Breastfeeding Services, I think, or you can search my name, or my name is in the comments or something like that. I try to make sure that I put a lot of good information up there on my Facebook page. I do add some pictures and stuff to my Instagram. Every year we do a Lift Every Baby event, which is a Black breastfeeding. I think Black Breastfeeding Week calls it Baby Lift Up, but we basically lift our babies in the air. This year we did it at 2:30, and it was super fun. And it's just a celebration and something to normalize breastfeeding, in our area that we do for the community, with all kinds of different people from many races, creeds, colors, socioeconomic status. I don't care. You come out. We feed you good, live, healthy food, and that is just super important, to me, is diet. And so, yeah, come and check me out, and I will probably be doing some more of these because it was kind of fun. It wasn't as, I was really, really, really nervous when I got on here. So I don't know who all is on here, but I do want to say that if you are a mama, especially if you are a woman of color, we need more women of color to be IBCLCs, to work in maternal health care. You know, I don't care if it's L&D, postpartum, you know, if you want to be an OB, whatever you want to be. We need more representation of us to work, you know, with us. And the research shows that, you know, as well. So, you know, I encourage you to, you know, get out there, find out the information, get trained up, work with those people that are in your community, and just keep loving on each other. And even though we don't all have a village, we can make a village. And it's important for us to support each other.